Professor Schwitter presentation. We had missed this opportunity before, but now it seems that everything is okay from the technical point of view. So, Professor Schwitter, you are going to present an overview of a large case series. Thank you very much, Professor Goethe.
Thank you very much for this talk. I would like to mention that I took over this talk because the largest series are probably done by the Leipzig group in Germany, and they gave me data. They are working on a large series of patients that will be finished and published in a few months. So I have not yet these data to show you, but other data from Leipzig. So I took over. Here are my disclosures. I took over the task from the Leipzig group, so it's not my original presentation, I would say. So the content here is, I would like to show you a little bit, 2-3 slides, what we did here when we started our own interventional MRI center, and we are doing now flutter ablations. Then I will give you some ideas about the infrastructure of such a lab, then on the workflow for flutter ablation, and then the outcome data and some characteristics of 2 large studies from the Leipzig group, and 2 questions at the end. So this is an overview or a summary slide of what we did in November 26th. So we did our first patient successfully in our interventional lab. So you see here on the left side the preparation room, which is just opposite to the MR room. And then in the MR room, you see the equipment that is used and the people that are working there. It's Etienne Privot, who is the chief of electrophysiology of the electrophysiology lab, and James and Hélène as technicians and nurses. And then you see on the right a lot of people in the operator room, some of them sitting at the consoles and working there, and many others that were just interested to see what we do, because we knew this will be the first case we do. And this lab is done here under guidance of cardiologists. So I'm in principle responsible for it, but we do it in close collaboration with the radiologists. So they help us. They are here. The technicians are here. So we work very closely with the radiologists here in Lausanne. And here is the North Star that we use. This can be coupled to the interface of a Siemens machine, as Marco added, explained by XSI. And just to give you an idea, when we did the case, so this is, you see here all the points that we already did. This is the catheter that burns, and this is the catheter, the symbol for the catheter in the coronary sinus. And by North Star, you see here the 3D map, so you can change the orientation of these shells of the inferior vena cava. And we are at the end of the procedure, and you measure here the delay time from excitation in the coronary sinus, goes it to the receiver point here, which is the ablation catheter. So in the beginning, you have a fast excitation going through, so there is excitation, and immediately you see the signal here. And now if this is closed, this line, the excitation will go around. So it will take you more than 100 milliseconds or so between excitation and sensing the signal here. If you have more than 100 milliseconds delay time, now we call that a positive result compared to the initial state.
Robin.
You're done?
No more.
Sure? One more. No, I can't hear you. We are done, right? One more. One more. One more one. One more point. Sorry?
We are done.
We are done now. Okay.
Bravo.
So this was the end of this exam, and you see there was a question whether we should repeat one of these measurements, but everybody was happy that the numbers are correct. So we finished, and it was a successful end of this intervention. You see here in the background the MR machine here, and so Etienne is working here, and you communicate with him by a headset. And this was the group where we started our center here. It was several years of planning, to get the center installed here in the University Hospital of Lausanne. But it was a big achievement because it was built here from scratch. So there was a lot of negotiations with the government, etc., to install a new machine, etc. But finally, we get all the green light from politicians and finance departments, etc., so that we could do it. And you see here the people that worked on the first patient, and it was a very, very good day for all of us, also for the patient. And this is what you need. This is, as I said, a new center, so everything was installed from zero, but you can also have a scanner which is used for routine diagnostic procedures, in imaging procedures, and you can add a few things that you should have, and then you can convert a conventional diagnostic imaging device into invasive device, so you don't need to buy a new scanner and construct everything from scratch. What you need here, I start here. Top right, top left, you see the optoacoustic system. So there are such cameras in 1, 2, 3 corners, and they connect visually with this headset, which is here worn by Etienne Privot. And then we have the same devices outside, so we can talk to each other. Also, the anesthesiologist is, in this case, outside because it was a very simple anesthesia. So you can communicate with this system here with the headset, because you can have some noise when you do scanning. If you don't do scanning, there is not a noise usually. And then you need also an MR conditional ventilator, which is here. So we intubate the patient from the back of the bore. Then you need MR compatible catheter. So this is the Vision MR ablation catheter. Then there is a diagnostic catheter. And there is also an introducer, so a sheet that you can manipulate better the catheter inside the right atrium. Then there are screens here that you see what you see before. It's mirrored what we see outside here. They see inside, so they see the mesh of the heart with the dots and the ECG that are recorded in real time. So these screens are delivered together with the North-South system. Then you need an Advantage MR recorder, the stimulator system here that produces the energy to inject the RF energy. You have a monitoring system, which is MR conditional. But with these things here, you convert the diagnostic room into an interventional room. And you can hire, for example, this room for half a day a week or something like that, and do your interventions there. And then outside, you need this ablation generator, which is located here, and the North-South system, which is sitting here. So with these components, you can do your interventions. And what I was informed by Steve Edan, the CEO of the Imricor company, they have a nice overview of what is done with flutter ablations worldwide. And you see that there are more than 400 cases done so far for flutter ablation in the MR environment. And this is done in more than 10 countries. These are the countries that do actively flutter ablation procedures in the MR environment. We just started here. And the biggest series, I would say, is probably in Leipzig. I don't know whether what is the numbers of other centers, but there are certainly others which are also very active in this field, because more than 400 is a quite large number. So I would like to show you, from as I know, currently the largest number is 30 interventions done in the Leipzig Heart Center, and they did also 30 controls in the conventional lab. And you see here the comparison between the control group here and the MR group here, and they are very similar. They had a little bit higher blood pressure, but otherwise everything was identical or not different between the two groups to start with. And here is just that you saw it also before in this little movie and in the presentations of the previous speakers. You see here, for example, in green, the right atrium. So it's a mesh and the points are inside this mesh. You see the catheter, and you typically acquire these data before you start the intervention. We do that usually a week or so before, so we can work on that to see what we have, and then we just align it during before the intervention. And this is now this quite large study. So the procedural definitions were as follows. So the temperature limit was 41 degrees. So the catheter, the ablation catheter, can also measure the temperature. And if the temperature exceeds a certain limit, it stops the RF injection into the tissue. It can go up to 65 watts. So in this current trial, that is a multi-center trial, which is done by Imricor, we go up to 50 watts, but the machine can go up to 65 watts. And there are little holes at the tip of the catheter so that you can irrigate, you can inject fluid in the environment, in the vicinity of the tip, so that the energy can better penetrate into the deeper layers of the muscle. So if there was an incomplete reach of the ablation catheter to the tricuspid annulus, this was addressed by manually adjusting the catheter tip prior to the sheath insertion. So that you can do. Now there is, at that time it was not available, but now there is a sheath available so that you can manipulate easier the catheter in the right atrium. They also could do some pullback loop maneuvers. I'm not an electrophysiologist, but you can, with that, you can go to deeper levels of the isthmus or very close to the isthmus where it connects to the inferior vena cava. And then after procedure, they check the bidirectional isthmus block as the endpoint of the successful procedure if the conduction between the 2 points was through this line with a more than 100 milliseconds delay time, as you shortly explained during the video. So this was here the endpoint. The procedural endpoint was a bidirectional block through the isthmus line. I think in the future, in the left ventricle, then inducibility of tachycardias will be the endpoint, or imaging endpoints. If you see that you have completely ablated the point in the myocardium, that could be an endpoint, but here it's an electrophysiological endpoint. And then they looked for 3 outcome measures. So one was the primary safety endpoint, which is complications, serious adverse events during the procedure itself, and then during 1 week after the procedure. Then they looked for the interventional success rate, so a direct success during the intervention, so this bidirectional CTI block. And then the primary efficacy endpoint is the recurrence of atrial flutter, isthmus-dependent atrial flutter up to 3 months after the procedure. This is one of these measurements with more than 100 milliseconds difference. If you stimulate here, and measure here, and you stimulate here, and you measure down here. And now the results. 13 patients out of the 30 patients, they had atrial flutter before starting the procedure, so they were converted into sinus rhythm. So at the end, all the patients that entered the procedure were on sinus rhythm. The safety endpoint was achieved during the procedure, no serious adverse events during the procedure, and also no serious adverse events during the first week of the procedure, which is very nice to show that this is a safe procedure. Numbers are relatively small, but very encouraging results here. And then if you look for the outcome, the success rate, are there relapses of flutter? There was no relapse, so complete maintenance of sinus rhythm in 93% in the MR guided interventions, 100% in the control group, and after 3 months there were no recurrences in the MR group, and I think 1 case in the control group. So very good numbers. Then here are some other characteristics of the population they did in Leipzig. This we know already, and here are some outcome data. what was measured in the MR during the intervention. So you see the length of the isthmus, the in systole, in diastole, etc. And I think what I marked here is probably an important point to be sure that there is no relapse, is probably the complete ablation, so an edema, late enhancement here in the isthmus zone. So if you have late enhancement throughout the isthmus zone in 100%, they had no relapses. So this is probably an indicator that this is a good ablation. And then microvascular obstruction that you can see during if you apply these sequences, you can see microvascular obstruction in the isthmus. 100% of the patients showed this feature. So this is a very bright rim here, and then in the middle of this high signal area, there is a black core. Microvascular obstruction, meaning that this tissue is completely destroyed. And I think this is probably a good outcome measure. And edema, all the patients had edema, but I think if you measure edema by T2 weighted imaging or T2 mapping, if you have edema, this is not a proof that you did necrosis. So if you have only edema and not necrosis, this is probably the patient that could go into relapse. And this is how it looks like. So this is before the intervention with T2 mapping. So no edema here. After intervention, there is edema. You can also color code that, and you see the edema. But I think edema is not what we primarily want to produce. So this is what we want to see. This is late enhancement in the isthmus from the inferior vena cava to the tricuspid annulus. And you see here these dark dots in this area. So if you have these dark dots, that means that this is microvascular obstruction, very severe, this damage of the tissue, and probably no relapse in this situation. And then this is the procedure characteristics of the procedure. If you do that in the MR scanner room or in the conventional room, and you see the interventional procedure time, it is not different. So it's very similar. So you, at the moment, you are not faster, but you are more or less at the same time. And if you look as an indicator of how well you can manipulate your catheters within the anatomy, you have a very good 3D visualization of the coronary sinus. So there is a difference, and you see that you are faster by cannulation of the coronary sinus compared to controls. This minute difference or so is certainly not relevant compared to the whole procedure time, but for me, it's an indicator that the 3D anatomy that you see is helping you to guide the catheter into this little hole. That means you can target this coronary sinus better than here. And if you target the coronary sinus, you may also target other locations in the atrium or in the ventricle more precisely. And this means you can go probably more precisely to the lesion that you want to ablate than this technique. They also looked at the learning curve. So they started, this is 6 groups, so each group has 6 patients in, and they started here with a relatively long procedure time. And you see that after about 12 patients, the curve goes down and flattens. So they concluded that you need about 12 patients to get to a stable performance in your interventional MR lab. So it's not very difficult to acquire the skills to use these catheters if you are an experienced electrophysiologist. So an experienced electrophysiologist needs maybe 10, 12, 15 cases, and then he's in a stable situation. Also, coronary sinus cannulation was a little bit longer at the beginning, but once you are used to use the machine and the environment, you get this done very fast. We also looked with data from Leipzig in a collaboration with the Leipzig group. We analyzed the motion of the isthmus, because here we see still here we have some differences in performance time. It can be 30 minutes, it can be 45 or only 30 minutes, or here more than 50 minutes. So this difference in complexity or duration of the atrial ablation, what is the reason for that? I think it's not only the length of the isthmus, but other reasons. So we hypothesized it might be the motion, the extension of motion here. If you have a lot of motion, you may have less good contact with the catheter to a blade, and it might convert into a long procedure time. So we did this analysis, and you see here that further away from the insertion point here of the atrium with the inferior vena cava, if you go down to 5, you see more excursion, so it moves much more here than it moves here. This is in systole of the atrium. This is in diastole of the atrium. And if you see the motion, you see most of the motion is anterior posterior, so this direction, and only a little bit motion this direction. So most of the motion that we see here is in this direction. And we normalize elongation like strain. And this is a graphic of a patient where you see a lot of motion here. So contraction goes in this direction during the cardiac cycle. And here you see a patient with hypokinetic isthmus motion here. Most of the patients that had a electrical conversion before the scan were in this group, probably because of stunning. And we also found that there is a correlation between this excursion of the isthmus motion. It is less evident in smokers, in patients with hypercholesteremia, and in obese patients, and in those, as I mentioned, which underwent electrical conversion before the intervention. And interestingly, so we found this correlation, which can have an impact on the motion of the isthmus, but we did not find a correlation between the motion of the isthmus and the duration of the procedure. So obviously, the excursion, the extent of motion here is not a major factor that influences the complexity or duration of the flatter ablation procedure. And then I want to show you this study also from Leipzig, because they included also more than 40 patients in this study. This study was published primarily to show how you can acquire the 3D map of the heart that you use then to generate the mesh, and on this mesh you can then orient your interventions. And so here they started with a new technique, which is very fast for a very nice 3D acquisition of the heart. So this tells you here, this slide tells you how they do the procedure. So they do the T2 imaging before they start the procedure. Then they do the non-selective whole heart compressing acquisition of the whole heart. Then they do the segmentation here to get the right atrium, the vena cava inferior superior, and then they do the sinus. And then during the segmentation and generating the mesh of the 3D mesh of the heart chambers, they do some sinus, then they do the intervention, and at the end of the intervention, you can add T2 mapping for edema, and we also add here late enhancement to see whether we have necrosis or microvascular obstruction. This is just an illustration how these 3D meshes look like. So this is the atrium, the coronary sinus. You go with the catheter into the coronary sinus. You can rotate in any angle here in an ICU system from Philips, and you can do the same angulations and rotations in the North Star system from Imrico. And then if you have done the acquisition, in this case by this non-slice selective, very fast 3D compressed sensing accelerated acquisition, here you do the segmentation, then you do the meshing, so you get the cavities here, and then you can add to this information here where to go with the catheter. You can display the ablation maps, you can display the excitation map, and you can overlay other types of tissues to this mesh. This is just to show you what they measured, and in these 41 patients, and they applied about 18 ablation points, but quite different between 6 to 43 points. So there might be very easy ablations and very time-consuming ablations, and we don't know exactly why this happens. We have some idea, and we do some other analysis on these patients that we acquired, that we share with Leipzig, that we got from Leipzig, and with the cases that they do now and with the cases that we do now, we go for other parameters that might predict this big difference in ablation points and complexity or duration of the procedure. And you see here the maximum conduction time difference was more than 100 milliseconds, which means that the procedures were all successful in the acute phase. And then they show that with this new acquisition time, it took about 1 to 2 minutes to acquire the 3D data. It takes half a minute or so to segment it. Then you correct, so the correction is needed at the moment, so there are a few minutes extra time, but you see within 10-15 minutes before scanning, before starting the real intervention, you can invest 10-15 minutes to get these very high resolution 3D meshes where you can navigate then your catheters. And in that study, they had 41 patients, and so we can combine these two studies. So we have the primary success rate. It was 93% during the intervention of blocks in the first study versus 100% in the conventional control group. And in the 42 patients that they did later on, they had a primary success rate in the scanner of 98%. So 93% or higher is the success rate during the intervention. It's a very, very high success rate. No safety issues also in that study, and recurrence rate 0 in that study. They did not report the recurrence rate on these 42 patients, and now they are working on a data set which includes the primary success rate and the recurrence rate after 1 month and 3 months, and I think also 1 year with more than 100 patients, but this paper is not yet ready to show. And yeah, this is what I wanted to show you, and I think we had to provide 2 questions, and so we are at the question point now, and one of the questions is like a take-home message from this talk would be: how many MR-guided air flutter ablation procedures are approximately performed so far worldwide? Are there more than 1,000 in 50 countries, 600 in 25, more than 400 in more than 9 countries, more than 100 in 4 countries? I think before the talk, I would have guessed something more like that. So I was astonished that there are much more interventions done. And I think everybody knew the correct answer is number 3. There are more than 400, and actually they are done in 10 countries now. And then we have the other question, the primary procedural success rate and the efficacy profile of MR-guided interventions that we do now as the state of the art today. We have 4 possibilities. So the primary success rate during the intervention, is it 93% or higher? And recurrence rate 3 months in the published literature so far 0%. Or are we at a success rate of maybe 85 and a little bit of relapses? Or are we down to 70 and 5%? Or is the procedural success rate 50% and the recurrence rate of 10%? I would remind you that if I'm not wrong, the procedural success rate of tachycardia ablation with conventional procedures are in the range of 50% today for tachycardia ablations in the ventricles. So 50% success rate is not something unknown in electrophysiology. But for this relatively easy procedure, if you do it, you are at a success rate of 93% or higher, and in the literature, relapse rate around 0%. So I think these are some take-home messages from this talk, and I hope you were interested. Thank you for your attention.
Thank you very much, Professor Schwitter, for your nice presentation. You presented really very important cases, and we got some certain messages. Just a very naive question. I was thinking to make the same question to Marco before. In the case that the patient has, let's say, often ectopics, like ventricular ectopics, do you have any problem during the procedure because you're using these MRI systems?
Yeah, that's a question that is probably best answered by electrophysiologists. We have now done 5 patients, so my experience is extremely small here. We had one patient that went into atrial flutter during the procedure, so we started in sinus rhythm, then he came into atrial flutter. We continued with the procedure, and during ablation, the flutter stopped, and he was in sinus rhythm. So this was not finally a problem. At the moment, I did not see extrasystoles during the procedures.
Okay, but possibly I'm wrong. I'm concerned about the visualization problem, not the electrophysiology problem. Visualization problems during the MRI. For example, here, please, Sophia, please correct me, but in many cases, if I remember well, if I could recall well, when we are asking for, let's say, an MRI stress test, and the patient is in many ectopics, the physician is getting concerned about the accuracy and the efficiency of this technique. So, in general, patients with often ectopics, do they represent a problem for the technique and its approval?
And I would say the extrasystoles in daily clinical practice are not so much of a problem anymore, because you can do prospective triggering and you can avoid bad image quality in extrasystoles. We do that also with atrial flutter. I would say that the volumes and ejection fraction estimations are a little bit less precise in these cases with atrial flutter, atrial fibrillation. For example, late enhancement you do in systole. So late enhancement gives you extremely nice quality, even if you have extrasystoles or atrial fibrillation. The quality is excellent if you do the late enhancement in systole, so this is not a problem. And you brought the point to during the examinations or procedures, you saw that the mesh, the model of the heart is static. It's not moving around. And so this is not very realistic. And we are now working on getting the motion into these models. So we got a big research grant from the Swiss National Science Foundation. And in one part of that grant, we will transform the static mesh into a moving mesh. I will show you in one of the next talks a little bit more about it very shortly. I discussed with Etienne Privot, our chief electrophysiologist, and he said to me, yeah, I have the Carto system without motion. We don't see the motion, and maybe it's better because we would be confused if we would see all the motion that happens. So we work on diastolic meshes that is produced by Carto, and I feel happy with that. Then he saw interventions in the MRI with real-time imaging, and then he was astonished that you have this large excursion of the tricuspid annulus and the isthmus, and he was a little bit surprised and felt a little bit uncomfortable, I would say. And I said, yeah, this is how the heart looks like during the intervention. And then he said, yeah, if he realizes that, it would be good probably to see the motion of the heart during intervention. So now we work on this aspect. We have a close collaboration with ADIS, which is a spin-off of the electrical engineering school of Lausanne. And ADIS has a collaboration with Imricor. So then in the next version of the North Star of Imricor, so the navigation system, it will contain the software of ADIS. And the ADIS software will provide a motion of the heart and also the breathing motion of the heart. So we will see a beating heart with breathing motion on top of it, and then the electrophysiologist has to put the catheter on the heart. It will be a little bit more difficult, I would say, but he will see what he's doing. So the next version will be much more real compared to what we see today.
Yeah. Okay, so possibly if there is not any other question, we have to move to the next presenter.